The views expressed on the Jerry Cahill CF podcast are that of Jerry Cahill and guests, and not necessarily those of the Boomer Esiason Foundation. Nothing on the Jerry Cahill CF podcast should be considered medical advice. Such advice can only be given by a physician who is experienced with cystic fibrosis. The Boomer Esiason Foundation, Jerry Cahill and guests cannot be held responsible for any damage which may result from using the information on this podcast without the permission of your medical doctor. You're listening to the Jerry Cahill CF podcast presented by the Boomer Esiason Foundation and jerrycahill.com.
Welcome to Jerry Cahill's Living, Breathing, Succeeding podcast series, The Path Forward with CF. This show was made possible through an educational program from Columbia University Medical Center and the Lung Transplant Project to the Boomer Esiason Foundation. I decided to take a deeper approach into lung transplantation with this series, as I've been through the process of transplant, and I know a lot of people out there have a lot of questions about it. So we're going to start off with the pre-transplant process.
I'm Selim Arcasoy. I'm the medical director of the lung transplant program at Columbia University, New York Presbyterian Hospital. I've been here serving this role since 2001. A CF patient should think about lung transplantation when his or her lung function is declining. There are some other important clinical factors that need to be considered, such as increasing frequency or resistance of infections, increasing exacerbations that require hospital stays, particularly if they require intensive medical care unit hospital stays. Other factors that need to be considered include coughing up large amounts of blood, that is called hemoptysis in our medical lingo. And another factor that doesn't get considered in the listing system, but is very important in transplant referral, is pneumothorax, which indicates lung collapse. If lung collapse occurs, and particularly if it recurs, it's a strong indication for transplant referral. One of the questions that is frequently asked is what level of lung function is appropriate for transplant referral. And years of study and experience have shown that FEV1 level of 30% or below is a significant indicator for need for transplant referral. Although several studies have tried to identify better predictors for transplant referral, FEV1 of less than 30% remains a good guidepost for transplant referral. Having said that, there are some patients out there who have better lung functions, higher FEV1s, but have had frequent exacerbations or a more rapid trajectory in their course. In that case, we don't wait for lung function to drop to those levels, but would like to meet them sooner than later. CF patients should be concerned about having resistant organisms, although usually that does not represent a contraindication to transplantation. The reason why there should be concern is the fact that transplanted lungs are attached to the main airways on each side, and it's always done as a double lung transplant procedure. Therefore, the sinuses and the upper airways, particularly the trachea, still belongs to the cystic fibrosis patient and has cystic fibrosis in the lining of the respiratory tract. Therefore, resistant microorganisms tend to still live in the sinuses and the trachea and can potentially infect the transplanted airways. Having said that, once we remove the largest burden of resistant organisms, which are the lungs, we're usually able to deal with resistant organisms with antibiotics after transplantation. Up until May of 2004, lung allocation was a first-come, first-serve type system. In other words, patients were seen by transplant centers. They were placed on the list as soon as they were evaluated so that they could accrue 2 to 3 years of waiting time and climb to the top of the list before they could be offered organs. In May of 2005, the system was changed to include something called the lung allocation score. What lung allocation score is a numeric value that represents medical urgency or priority of a potential transplant recipient on the waiting list, and is calculated based on the underlying disease as well as all the clinical characteristics of a particular patient. All the tests that we perform in our evaluation as well as other factors such as the patient's age, kidney function, their underlying disease, go into calculating a score that ranges between 0 to 100. Patients who are sicker on the waiting list and have the highest risk of dying on the waiting list get assigned a higher lung allocation score, and then they rank higher on the waiting list. This way, we could transplant patients who are most likely to die sooner than later. One of the factors that the lung allocation score also takes into account is post-transplant survival. However, the way the score is calculated is heavily weighted towards pre-transplant survival on the waiting list. Indeed, in the formula, it's 2 times waitlist mortality minus post-transplant mortality that calculates net transplant benefit. In other words, patients who have the highest risk of dying on the waiting list end up getting prioritized. This system is a good system in prioritizing sicker waitlisted patients. However, it does not take into account longer-term post-transplant survival, in other words, at 5 years or 10 years, and may, to some extent, disadvantage some of the diseases like cystic fibrosis or pulmonary hypertension. In terms of optimizing the lung allocation score, since it's calculated based on fairly objective medical criteria and some things that cannot be changed, like age and disease, it is hard to do so. Some of the factors that are important to know that go into calculation of the score include pulmonary function testing, 6-minute walk test distance, the level of pressures in the pulmonary circulation that we measure with echocardiography or right heart catheterization. Since these are the factors that we use, they're really not they're not factors that could be manipulated. So one of the questions that I get asked during education seminars is whether patients or providers can manipulate the lung allocation score. And for the most part, the answer is no. In other words, we calculate the score based on objectively measured parameters, as well as how much oxygen that a patient needs. So if a patient reports that he or she needs more oxygen than he or she actually needs, then we could easily detect that in our office visits. So in other words, although there are ways that people may try to manipulate the lung allocation score, is typically not possible. If a patient tries to underperform pulmonary function tests, we could usually detect that by the flow volume loops that are generated during testing. Or if somebody starts crawling during a 6-minute walk test, as opposed to properly walking, their oxygen saturation levels are monitored, and the physical therapist is continually keeping an eye on the patient. So it's hard to gauge those, it's hard to manipulate those test results. One of the questions that people ask, particularly in their first visit with our transplant center, is what obstacles would there be during my evaluation that would prevent me from becoming a transplant candidate? And I like to think of these as potential medical obstacles and psychosocial obstacles. Medical obstacles include things like the finding of significant other organ dysfunction, such as significant kidney insufficiency or significant liver disease or significant heart disease. In case of cystic fibrosis, sometimes it's the finding of a very difficult microorganism to treat. Cystic fibrosis patients are very well aware of the impact of Burkholderia cynocepacia. If their respiratory cultures continually reveal this organism, a lot of transplant centers do not feel comfortable offering transplants for these patients. Other potential factors include things like active hepatitis infection or things that we cannot treat well under the effects of immunosuppression. The other broad category I mentioned is psychosocial obstacle, and this may include things like patient health behavior, such as lack of compliance with follow-up or medications, or lack of a good support system in place that is essential for post-transplant success. Things like drug, alcohol, nicotine use or abuse are also considered psychosocial and significant absolute contraindications to transplantation. There's a concept called multiple listing or dual listing, meaning that patients can be listed in more than one transplant center if they have the resources and physical stamina to pursue that. This is available to all patients, although there's a unique law in New York State which does not allow dual listing within New York State for patients. In other words, a patient cannot be listed, say, in New York Presbyterian Hospital in another program within New York, but the same patient can easily be listed in a program in Philadelphia or Maryland. Typically, we would tell patients that they're able to do this legally, and that we would recommend it strongly if we're worried about them. So if they're really sick, or if they have a rare blood group, or if they are extremely short, that makes size matching and organ availability more difficult, we may counsel them to seek dual listing or multiple listing so that they could be brought to transplant on time. However, multiple or dual listing requires going for the patient and his or her family to go to another center, getting tests done. So travel when you're sick is quite challenging for some of the patients. Once a patient is evaluated and listed for transplant, they're typically followed closely in our program. Our set interval is every 2 to 3 months. That's adjusted based on how sick the patient is. There are certainly patients in my practice who are extremely sick who I like to see every 4 to 6 weeks to make sure they're okay. And there are others who are not so sick and they could be seen every 3 months safely. During these visits, we talk to our patients, examine them. We look at their medication lists to make sure there are no substantial changes. We also periodically assess their pulmonary function tests, 6-minute walk tests to evaluate their functional status. Their psychosocial assessments are repeated intermittently every 6 to 12 months, or more frequently if needed, if there are concerns that have been identified in the past. So if a patient is determined to be a good candidate and happens to be listed, but stops showing up for pre-transplant visits, that's typically a red flag, and we would not keep that patient on the active list until he or she can demonstrate that they could follow up with our program.